Welcome back to the OHSU Effect Inside Health and Science. I'm Lacey Evans. Good morning. And Dr. Albert Starr and Dr. Sanjeev Kaul are with me now. And a surgeon, a heart surgeon, and a cardiologist working together kind of makes sense, right?
It does, yes.
We want to talk about imaging because, Dr. Kaul, that is kind of your specialty. So first, explain what imaging means in relation to the heart.
Okay, so about 50 years ago, if we wanted to see what was going on in any tissue in the body, let's say a cancer or a heart problem, we would have to do an autopsy. Now we can look with the same precision from outside the body using CT, MRI, X-ray, radioisotopes, so on and so forth. And not only can we see them from outside the body, we can see them moving in real. The heart moves, unlike the brain, and so see it moving in real time. So that is the function of the heart. In addition to that, with imaging, we can look inside the molecular mechanisms that are participating in the control of the heart muscle. For example, we can let us say that the heart uses fatty acids for its energy. We can label the fatty acids with an isotope, inject the isotope, do positron emission tomography of the heart, and see how the heart is consuming this fatty acid. Is it consuming fatty acid or is it consuming oxygen? If it's consuming oxygen, we know the heart is ischemic and is not working properly. We can take a technology that I helped develop called contrast echocardiography, where we use small microbubbles filled with gas, and they behave like red blood cells in the system. So if we inject them, they move like red blood cells through the body, and we can use ultrasound to track them, and so we can measure flow through different organs, including the heart muscle. But what we have done is my colleagues have helped develop a technology where we can put ligands or moieties on top of these bubbles so that these bubbles can then stick to abnormal tissue, so like an antibody. So instead of just looking at function, we can even look and see where abnormal molecules are expressed, and they are particular to a disease. And then we can take it further. On the bubbles or inside the bubbles, we can put genes and drugs. So we take the bubble, goes and sticks to abnormal tissue, and then we can zap the bubble with high energy. It breaks, and the gene and drug is released locally into tissue. And all of this can be visualized in real time simultaneously, so that whatever we do, we are seeing it happen in real time. We talked about the valves a little while ago, and what has helped the valves, percutaneous valves, is that we simultaneously do ultrasound of the heart by putting a probe in the food pipe from where we can see the heart very closely. And we can see the catheter being deployed. We can tell the person is being deployed at the right angle. So this kind of imaging has completely transformed the way we take care of patients.
So put in simple terms, in the old days, we would have to make a big incision and look around. And then we started using fluoroscopy. For example, when pacemakers were first developed, surgeons put in pacemakers, and I would stand around in the catheterization laboratory and be exposed to X-rays while I was putting a pacemaker in. I was very happy to turn it over to the cardiologist as soon as I could. But using the X-ray technology, it's possible to get an image and actually be able to do a procedure using that as your guide instead of light rays.
Well, I was going to ask, how, as a surgeon, are you using this imaging information?
Well, as a surgeon, we're working in a hybrid laboratory where some things require a small incision, and then it requires the skill of a cardiologist in manipulating the catheters inside the system. So it's a great teamwork and it gives them access that is we as surgeons can give the cardiologists access that they otherwise might not be able to obtain. Another method, for example, of putting in a aortic valve, which we can do now through a femoral artery in the groin. If that artery is diseased, we could go directly into the aorta. Now, the cardiologists couldn't do that themselves, but the surgeon exposing a small amount of the aorta for them would enable them to give them access. So the teamwork is really important, and then the sophisticated devices that give us perfect positioning of all the instruments inside is another important element.
So, for example, Dr. Starr has repaired many valves, not only replaced them. He takes a valve, and if he can repair them, he'd rather do that than replace them. And in repair, ultrasound has been very crucial. Again, putting it through the esophagus, food pipe, simultaneously showing the surgeon what's going on, and then testing if it's leaking after they do a repair. You can test it there and then in the operating room. And that has completely revolutionized valve repair.
Because what would you have done before? Would you have just gone in and assumed that the whole valve needed to be replaced?
Yes, if you didn't have a sophisticated way of determining whether the repair was adequate or not, you would lean towards replacing the valve. But with echo guidance, echocardiographic guidance, and the probe in the esophagus right behind the heart, you could see the valve function after you did the repair, but while the chest is still open, and know that you have done a good repair.
So how is this benefiting patients? It obviously sounds like it's less invasive and prevents the need for unnecessary surgeries. But tell me about the benefits to them.
Okay, so the most important benefit is diagnosis. So we can make a diagnosis of almost anything. In fact, our autopsy rates have gone down tremendously because we really don't need autopsies, because it is very rare, maybe 1 in 500, that we don't know what's going on in a patient by the time they have expired. And that's all because of imaging. Whether it's CT or MRI or ultrasound, we can see everything. And so we make all the pathological diagnosis without literally needing a pathologist. The other example I will give you where imaging is helping a lot is electrophysiology. This is where we put catheters in the heart to burn out parts of the heart muscle that are causing rhythm problems. This is a very complicated thing. The heart is three-dimensional structure. To get to the right spot, you need to understand the anatomy of the heart. So they do a CT and an MRI before, from which we construct the heart as an image. Like you must have seen, like a 3D image. We construct the heart so they know exactly what the heart looks like when they put in the catheter. Then inside the heart, they put in a tiny ultrasound catheter that tells them exactly where they're going. So it is with imaging that they can perform such sophisticated ablations and things like that.
And I would imagine this is good for your students, too. They can practice with these 3D images, right?
Well, they certainly follow what you're doing, you bet.
I will tell you something that's happening. That is, these ultrasound machines that we first started using were as big as refrigerators. Now they are as big as my iPhone.
Wow.
And now we are teaching medical students how to use these machines rather than the stethoscope. Because although the stethoscope looks very sexy on a doctor, it's pretty pathetic, quite frankly. And most doctors don't know how to use it.
I use it only for photography purposes.
Yes,
right?
You see? And so it's a great icon. But we are now teaching people to replace this icon with small ultrasound systems that they can put in their pocket.
Wow.
Yeah, I think the takeaway is that these new imaging techniques facilitates the treatment of heart disease. But as Sanjeev said earlier in his remarks, really important stuff is being learned at the molecular level by very sophisticated contrast techniques using the microbubbles in which he is the pioneer. I mean, this is really Nobel Prize kind of material, and we're very excited about what we're learning about actually how the heart muscle and its blood vessels work at the molecular level, and that will give us a chance to control heart disease even better than we do now.
Yeah, because I want to talk about some things that people can do to protect their hearts and prevent disease. What are your top 5?
Be born with good genes. Choose your parents wisely. Then don't smoke. Don't go near a cigarette. Keep your blood pressure under control. That means you've got to see doctors. Cholesterol must be under control. And exercise and good diet. That makes it 6. But people think that if they have the right weight, they don't need to do exercise, which is not true. Exercise adds much more benefit even if you are not obese. But diet and exercise together gives you the right weight. And if you don't gain weight, that is one of the greatest things you can do in terms of keeping yourself healthy throughout life.
Good. Well, simple stuff. Well, our next segment is just 5 minutes away, and we want to talk about congenital heart disease, which is something, Dr. Starr, you know a lot about. So we're glad that you're here, okay?
Okay, my pleasure.
More of the OHSU effect next.